Dear friends, I am going to talk about endoscopic third ventriculostomy, complication avoidance. The hydrocephalus is a common surgical condition. ETV is an effective alternative to the shunt for treatment of hydrocephalus. It is safe in properly selected cases and with good post-operative care, and when the ETV is performed by the experienced surgeon. It is treatment of choice in obstructive hydrocephalus, and it is also useful in selected communicating hydrocephalus with anterior and inferior bulging of the third ventricle. But the results are not good in post-hemorrhagic and post-infective hydrocephalus in the acute phase, and it is also technically demanding. But the results are good in the chronic phase of the disease. Regarding the complications, interventricular bleeding is the most important complications. So avoid wrong side entry into the lateral and third ventricle, and also avoid the significant linear movement if you reach at a wrong place in the third ventricle or in the lateral ventricle. You can use the rotation of the whole set, and if the nothing works when you are at a wrong place, wrong trajectory, or wrong planning, then it is better to abandon trajectory rather than going for linear movement and producing bleeding. Open forceps or balloon to enlarge the stoma at the stoma, and do not open it below the stoma and try to pull it back into the third ventricle. In such case, it may catch the perforator and cause bleeding. Use brain cannula for ventricular puncture. Do not use directly the endoscopic site and puncture it. And the sheath which you are using should not be sharp. Regarding the treatment of the intraventricular bleeding, the copious irrigation of the warm ringer solution should be done, and if all small bleeding usually stops with patients. Inflate the balloon catheter or gently keep the instrument or the sheath on the bleeding point rather than trying to take it out and bringing the bipolar forceps. By the time the whole thing will become red and you will not be able to see the bleeding point. Maintain the ventricular access in severe bleeding by keeping the sheath within the field. You can retract it slightly and bring it in the lateral ventricle, but don't take out the whole sheath and endoscope. You can take out the endoscope. So this is the diagram which shows that if you are, this is a correct trajectory at the foramen Monro in the lateral ventricle, but if you have gone too much posteriorly or anteriorly and then try to move, and then there will be tearing of the ependymal lining and bleeding may start. And likewise, this is a good trajectory reaching the third ventricular floor in the midline as near to the midline as possible, going through the foramen Monro, and same in the sagittal plane, the correct trajectory. Whereas these two are the wrong. If the burr hole is made too much laterally, or if you have gone in the other side lateral ventricle and gone through the foramen Monro opposite side, then you will tear the both fornix and same side fornix in this case when you try to bring your endoscopic site in the midline, because by choosing this trajectory you will go and hit the opposite side hypothalamus area in the third ventricle, and if you try to come in the midline, there will be bleeding. If there is a bleeding, re-inflate the catheter. The repeated introduction of the scope without using a peel of a sheath or any other sheath is may also give rise to bleeding, so avoid this. Perforation on the dorsum celli, or use water jet dissection when there is a thick floor. Avoid sharp perforation, use blunt perforation in a transparent floor. Avoid blood trickling along the endoscopic site. So before entering the lateral ventricle, go for proper hemostasis. Avoid curved tip removal of the flexible scope. It may cause bleeding. So the curved tip should be made neutral, straight tip when the flexible scope is removed. So once the bleeding stops by continuous irrigation or other methods, then it is better to remove the intraventricular bleed. And if there is some oozing, then keep the EVD. Forceful irrigation and or blockage of the irrigation channel only for short duration allows the bleeding point, and then you can use bipolar coagulation. Fluid should be replaced by the air, equal amount of air. This is known as dry field technique, and then you can see the bleeding point very well and go for coagulation. If nothing works, then it is better to use tubular retractor in the air media, and the bleeding point can be controlled. The other complications, fornix injury, which is quite common when there's a small foramen Monro. So proper case selection with enlarged foramen Monro is advisable. You use a small size scope or flexible scope in such cases, and shrinkage of the choroid plexus by bipolar coagulation. Keep the scope in the lateral position near the fornix rather than forcefully going through the fornix and injuring it. Do not go for ventricular penetration exceeding more than 6 centimeters from burr side. Flexible scope should be removed in straight tip position, and enter the ipsilateral lateral ventricle and foramen Monro should be identified by location of thalamostriate vein and the septal vein. If you wrong on if you go on the contralateral side, abandon that trajectory. You should also avoid any linear movement, which we have already discussed, if the planning of burr hole or trajectory is wrong. In that case, rotation of the whole endoscopic site is permitted. When the working channel is placed anteriorly, you can rotate it and move it posteriorly. And even if it does not work, then it is better to abandon trajectory. So there should be either no linear movement or slow movement of 5 millimeter can be done. This usually does not injure the fornix. So this shows that you can rotate the whole endoscopic site. The hypothermia is another complications. So avoid hypothermia by temperature monitoring, especially in infant and children, and use pre-warm blanket. Also use pre-warm irrigation fluid and use it judiciously. Do not use it too much. Avoid wetting of the drips by using the drainage line connected to the outflow channel, and prevent hypothalamic injury. If you are off midline, then do not do any perforation in third ventricle floor. Another complications is hypothalamic damage. So making perforation at the most transparent site is a better option rather than going off midline. Start low current coagulation and then use the blunt perforation if the floor is thick. Avoid offline ventriculostomy to avoid damage to the hypothalamus. Bradycardia is another complications. Turn up the volume of the cardiac monitor and keep the noise of the operation theater to the minimum so that you can diagnose bradycardia. Check the outflow channel. Check that the outflow channel is open and the fluid is coming out from the outflow. Reverse the last action when there is a bradycardia. Use ringer lactate solution, which is near isosmolar and near the pH of the CSF, and use at body temperature fluid rather than too cold fluid, and also use gravity as the force for irrigation rather than too rapid and forceful irrigation and during ETV, even when there is a bleeding. Avoid stretching and traction on the hypothalamus by coagulation when the floor is thick. The failed ETV is another problem which may come across. Avoid ETV when there is a small foramen Monro or the small width of third ventricle. These should be sufficiently enlarged. You should open the floor of third ventricle at the dorsum celli rather than at the prepontine place. When there is a less space between the basilar artery and dorsum celli, when there is a small prepontine space, when there is a high sloping floor with high riding basilar artery. In such cases, open on the dorsum celli. Avoid ETV in thick and inflamed floor and use coagulation at the beginning if the floor is thick. If you come across interthalamic adhesions, then negotiate your forceps anterior or posterior to the interthalamic adhesions or coagulate it in the midline and cut. This is a large interthalamic adhesions, and this picture shows that when there's a posterior fossa tumor, this will push the brainstem and the basilar artery against the dorsum celli and ETV. Routine ETV will be difficult in such cases. So in such cases, it is better to use the forceps and make perforation on the dorsum celli as shown here. Block stoma is another complication. Avoid inadequate size of stoma. Always open it more than 5 millimeter. Avoid ETV in post-hemorrhagic and post-infective cases. They usually tend to block over time. Perforation of the membrane below the third ventricle floor. If it is there, at times there is another membrane after opening the third ventricle floor. So that membrane, which is either a Lilliquist membrane or any other membrane, it should be perforated. Avoid ETV when there is a tumor in the third ventricle, especially near the proposed stoma site. This may grow and block the ETV site. Use Omer reservoir or convert to the shunt when the stoma pulsations are poor. In doubtful cases, it is better to use ventriculostomography, in which dye is injected at the stoma, and if the dye holds up between 1 to 3 minutes, then it is better to put in Omer reservoir. If it stays for more than 3 minutes, then it is better to abandon ETV and put in a shunt in such cases. CSF leak after ETV is another important complications. If this happens, you should suspect that the stoma may be blocked and there is a raised ICP. So proper management of the raised ICP should be done. There should be delayed suture remover if you suspect this, or if there's a bulging suture line. Plug the cortical opening with Abgel and use Galeal pericranial flap and dural repair in a large ventriculomegaly, especially in infant. and make a small dural and cortical opening rather than opening it too big and inviting CSF leak. Delayed awakening is another complication. And so avoid long-acting anesthesia drug because the procedure may end very abruptly, and usually it is a short duration procedure. Avoid raised intracranial pressure, and you should see that there is a free egress of irrigation fluid from the outflow channel. Thank you very much.